Buenas tardes a todos, bienvenidos a esta cuarta y última sesión de este excelente simposio que realmente ha sido maravilloso para todos nosotros. Primero quiero partir por presentarme a mí y a mis co-chairs. Yo soy Soledad Undurraga, jefa de hematología del Hospital Salvador de Santiago de Chile. Me acompaña la doctora Mayra Pimentel, jefa de hematología del Instituto Nacional del Cáncer de República Dominicana, y el doctor Jorge Arbelbide, que es jefe de hematología y director del programa de trasplante del Hospital Italiano de Buenos Aires. Bueno, muchas gracias por estar acá con nosotros. Ahora tengo el honor de presentar a nuestra primera charlista, la doctora Valeria Santini, muy conocida por todos nosotros, no requiere mayor presentación, pero para la formalidad les digo que ella se formó en Florencia y también en la Universidad de Erasmus en Rotterdam y en el MD Anderson Cancer Center. Dirige el Departamento de Medicina Clínica y Experimental de la Universidad de Florencia y sus principales intereses son la mielodisplasia y la leucemia mieloide aguda en adultos mayores. Ella es presidenta de la Fundación Italiana para el Estudio de Mielodisplasia. Además, dirige el grupo europeo del proyecto Harmony 2020, miembro del board editorial de Blood, speaker internacional en múltiples congresos de EHA, ASH, ASCO, y bueno, tiene más de 200 publicaciones internacionales en revistas indexadas. Doctora Santini, bienvenida, adelante, muchas gracias.
Hello, my friends. Thanks for this very kind invitation. I really wish to thank the Latin American MDS group and the MDS Foundation for giving me the opportunity to speak about the treatment after hypomethylating agent failure. It's not an easy subject, in fact. This is an algorithm I prepared some years ago, and unfortunately we still are in the same position after 2 years. If a patient with a higher risk or lower risk MDS did not respond to therapy with hypomethylating agents, we have to reevaluate completely the state of the disease. And this includes also reevaluating possible presence of somatic mutation. If the patients are clearly moved and progressed to acute leukemia, of course the therapy choice would be different. But if the patient is still an MDS, we have to ask ourselves whether the cycles with hypomethylating agents were sufficient to determine a response. So in specific, whether he or she received 6 cycles of HMAs at least. If yes, then the performance status, the general condition of the patient will lead us to further choices, more for lower risk MDS, for higher risk MDS, apart from re-evaluating eligibility to transplant, and not as many as we would like, and mainly are experimental trials. Some patients may still respond to low-dose chemo, like low-dose RC, but it's a very, very small minority, and this kind of therapy is already obsolete. CPX351, it's another choice that we may opt to if we have a patient that is still in a very good condition and may have a response. Otherwise, we have to really choose to support our patients and treat within experimental trials. The fact are that hypomethylating agent therapy is the standard of care for high-risk MDS in Europe, for MDS overall, but only a part of the patients will respond, something like 40 to 60%. And the duration of response to the hypomethylating agents, it's in between 6 and 26 months, so it's not a definite treatment. And we have to talk about resistance to HMAs, specifying the two different possible mechanisms of resistance. In fact, we distinguish a primary resistance, so the patient has never achieved any kind of response to HMAs, or the patient has kept a very poor marrow, so a severely hypoplastic bone marrow that denotes lack of response. Or otherwise, and this is very frequent, there is a secondary or adaptive resistance. After any kind of response, CR, PR, or hematological improvement that has been maintained for a different time, the patient loses response, and this has to be, of course, reevaluated, but is indeed the resistance. And this two different situations may be encountered both in lower risk and higher risk MDS. We still don't know whether the mechanism of resistance in primary versus secondary resistance are different. The survival after HMA failure, as we know since several years, is extremely poor, with a median overall survival of around 5 months. We re-evaluated very recently a group of patients in our Italian National Registry who had been treated with azacitidine and then stopped treatment. These are a group of 402 patients, and as you see, at the time they stopped treatment, 44% had a secondary or adaptive resistance. 35% had primary resistance, so they never reached response. Some of them stopped even if they were in response. So for several reasons, because of probably they were not compliant, they had adverse event, or they had a planned stem cell transplant. Now, the overall survival of this patient who stopped treatment, it's different, of course, according to response, with patients who had a response and stopped in response, of course, having a significantly longer overall survival, where the other ones who received further treatment and had stable disease or progressive disease had an extremely short survival, and as you may see, with no difference with different type of response. But then we applied the recently published scoring system, the North America MDS Consortium scoring system, that allows to stratify patients after azacitidine discontinuation in two groups of high risk and low risk. And we actually confirmed and validated this scoring system. As you may see, all patients independently from further treatment had a much longer survival if they were belonging to the lower risk scoring. And patients who received best supportive care, as you see, again, if scored in low risk, had a longer survival. And when we analyzed subsequent treatment, the patients who had a significantly longer overall survival were only the ones who received stem cell transplant, whereas the other, despite being treated with low-dose chemo or other alternative treatment, were not indeed different among different arms of treatment. As I must underscore here that there were no patients treated with experimental agents. Only 3% around of relapsing patients are included in experimental studies. What happens about it? Unfortunately, many of the agents that were studied in MDS were not really active. There were a signal of activity of new hypomethylating agents in refractory relapsed MDS. Widecirtabine in a phase 2 study was used in high-risk MDS and CMML that in half of the cases had received prior HMA treatment, and the overall response rate was 43% in these latter patients. The same was true for CC486, the oral azacitidine, and the efficacy here for patients who relapsed was 35%. So, in fact, there was some signal of efficacy. That's why there was a phase 3 guadocytabine study exclusively in refractory and relapsed MDS high risk. These patients, 400 patients, a little bit more than 400, were belonging to IPSS categories 1, intermediate 1, 2, and high risk. And they received guadocytabine 60 milligrams square meter per 5 days, or a treatment of choice of the physician, low-dose RRC, best supportive care, or AML-like regimen. And the primary endpoint was overall survival. Unfortunately, this study did not meet primary endpoint, so there was no improvement in overall survival in patients treated with guadocytabine. Another single-agent study was the one that was evaluating the activity of rigosertib polokinase inhibitor versus best supportive care in patients who were relapsing or were refractory to HMAs. And again, the primary endpoint was overall survival. And this is the result. Unfortunately, patients who received rigosertib had a median overall survival of 6.4 months versus 6.3 for the patients who received other treatments. So, as you may notice, this was another study that did not meet the primary endpoint. There has been a number of studies that showed a poor efficacy of single agent in this setting, difficult setting of patient. Glasdegib had something like 6% overall survival. The same was true for the H3B8800 that did not induce any response, and ipilimumab was more efficient in maintaining stable disease than in inducing response. So we have to see whether salvage combination of agent is possible for a refractory relapsed MDS. And of course, one of the agents that was coupled to HMAs in refractory and relapsed patient was Venetoclax. The background being that apoptosis can be induced both by azacitidine and with a complete different mechanism by Venetoclax that has shown high activity in AML. So this study, there is a recent study that was designed because of the previous observation of something like 40% response to Venetoclax azacitidine in patients who lost response to hypomethylating agents. So the drug Venetoclax was added to standard dose azacitidine from 100 milligrams for 28 days to 400 milligrams for 14 days. And the study was carried out in 44 MDS patients. The primary endpoint was in fact a safety and maximum tolerated dose, and only the secondary endpoint were assessing the efficacy. Elderly patients, anyway, achieved an overall response rate of 41%. But the patients who could prolong treatment to 6 cycles achieved a response rate of 83% with a median overall survival of 12.6 months. So indeed, a significant prolongation of overall survival. An important note is that in this study, the patient who carried TP53 mutation did not have a real advantage in overall survival nor in progression-free survival, whereas other mutations were not significantly correlated to overall survival. As I mentioned in my first algorithm, we may still think of target therapy in this setting of MDS patients. This is why I really recommend to reevaluate completely the disease when response to hypomethylating agent is lost. And this includes reevaluation of somatic mutation that have been, could be new and appeared during disease progression. So ivosidenib was evaluated in patients with mutant IDH1, and the patient that in part received already HMA therapy could respond in a very high percentage of cases. In this study, 75% of patients responded, and this is a quite promising result. The same is true for enazidenib, that was applied in patients with mutant IDH2. And this patient had received in the great majority, again, HMA therapy and lost response. 46% of them achieved a response with the target enazidenib treatment. So it is important to re-evaluate the presence of this somatic mutation, because although these drugs are still investigational for MDS, they can be a real salvage for these patients, although rare, with mutated IDH genes. These are further data. You see that the arm B of this study, presented a couple of years ago at ASH, includes patients with no response after 6 cycles of HMA, and they received single drug enazidenib 100 milligrams daily. You see that the overall response rate is 56%, and the complete remission are also 28%. So really encouraging results. But many patients do not have targetable mutation. So there are novel promising combinations in MDS that are used for the moment in de novo MDS and none in refractory relapsed ones, but still very interesting. Now there are more data on the combination of venetoclax and azacitidine that indeed show a very high response rate with 79%, and a really good proportion of the patient responding are showing CR with a long duration of more than 1 year. The overall survival is correlating with good response, with the longer overall survival correlating with the higher CR rate. Other agents with a complete different mechanism of action, like the anti-CD47 antibody magrolimab, more are coming in this sense with anti-CD47 activity, in combination with azacitidine, has shown quite good results. And as I mentioned, it's a complete different mechanism of action from the ones we just analyzed. It's the antibodies blocking the do not eat signal present on the leukemic cells and dysplastic cells, and the response rate was 91% in first line. So it could be that this kind of approach may be applied and used successfully in refractory relapsed MDS. What has to be said for this agent and for other ones is that its extreme activity in first line could in fact lower the number and percentage of patients who lose response to HMAs and guarantee a longer response duration. Anti-TIM3 antibody sabatolimab has been used with decitabine and azacitidine. Results with decitabine are available. TIM3 is a receptor that is present on leukemic and neoplastic cells and on immune cells, and it's synergizing with the HMAs. The response observed in patients treated with sabatolimab and decitabine are, although in a small number of patients, promising, the overall response rate being almost 60%. The single-agent activity in refractory and relapsed MDS and AML was not really extreme for sabatolimab, but maybe its use in relapsed refractory patients should be evaluated and investigated further. Now, there are other treatments that are not properly targeted, but almost like that, like the APR-246 that is reactivating TP53, and it has been used in combination with azacitidine, again, still here in first line. And the data are extremely intriguing because in MDS, the overall response rate is 88%. There is an American trial and a French trial going on, and we are hoping to see more successful treatment in first line, as I mentioned, to prolong response, to achieve a higher response rate. And I really hope that we can still design salvage treatment for the ones who will anyway lose response and need to be rescued. I really wish to thank you for your attention, and I will take any question.
Agradecemos a la doctora Santini por su excelente intervención. Ahora vamos a pasar a nuestro segundo conferencista, el doctor Rafael Bejar. Es oncólogo y hematólogo del Dana-Farber Cancer Institute y profesor asociado de la Universidad de California en San Diego. Él nos va a estar presentando los factores biológicos que predicen la transformación a una leucemia mieloblástica aguda.
Bueno, muchas gracias por la introducción y por la oportunidad de estar aquí con ustedes. Y la próxima vez sería mejor hacerlo todos juntos en Montevideo. Como hice la última vez, les digo que voy a dar la charla en inglés, que me conviene un poco más fácil, pero a las preguntas le trato de responder en español. We'll start with talking about biological factors that predict transformation to acute myeloid leukemia from MDS and other myeloid neoplasms. So I'll start by saying that myelodysplastic syndromes and AML are separated by an arbitrary divide. There's a line at 20% blasts that defines acute myeloid leukemia, but I'll argue that this is not a defined biological process that makes that transition. There certainly are patients who have lower percentage blasts that behave as if they have acute myeloid leukemia, and there are patients who have more than 20% blasts that are very responsive to the same therapies that we use to treat patients with MDS or other myeloid malignancies. I think it's important to understand, therefore, that blasts are a predictor of crossing this line, and probably the most powerful predictor, but there are several factors in patients who have lower than 20% blasts, or even lower than 5% blasts, that help us predict when they might ultimately cross over. So to understand this, I think it's important to understand what the mutational profile is of secondary AML, because when we find mutations that are largely confined to secondary AML cases, in cases that don't yet have that disease, we may predict their eventual evolution. So let's start with, I think, what I would consider to be the old or more simplistic definition of class 1 and class 2 mutations. In the old theory, class 1 mutations are those that generated proliferation in cells, things like FLT3 or NRAS or JAK2, part of growth factor signaling pathways. And these were mutations that often define myeloproliferative neoplasms. Class 2 mutations were mutations in myeloid transcription factors, like RUNX1 or the core binding factors, or MLL. And when disrupted, these would often lead to impaired differentiation. So these were thought to be largely culprits causing MDS. However, when you combine these mutations, you would get a cell that has this propensity to proliferate and an inability to differentiate. And that would lead to the accumulation of leukemic blasts. And several mouse models certainly bore out that this combination of mutations could create leukemia. But I think as we quickly learned in practice, the situation is much more complicated. We still cling to these early genetic lesions in transcription factors and other single gene mutations as the way we define and classify AML. But as I'll show you, as we've understood more about AML genetics, we're starting to refine how we look at this and consider groups that are defined on a broader set of mutations. So one example of that came from the Cancer Genome Atlas, where they sequenced hundreds of patients with acute myeloid leukemia with whole exome and whole genome sequencing, and they identified there were a much broader range of mutations that could possibly occur in these diseases. And there were some patients who certainly didn't have both class 1 and class 2 mutations. In fact, many of the epigenetic regulators were more frequently mutated in AML than we had previously recognized. And Eli Papamanel put together a wonderful study of hundreds of AML patients, trying to define them based not necessarily on their morphologic features, but based on their mutational profiles, and identified that there are several genetic subtypes of AML that could be identified with these groups. And in general, the mutations that we're looking for in AML are those that involve kinase signaling, DNA methylation, chromatin regulation, splicing factors, transcription factors, and others. And you'll find that some of them are more limited to patients with secondary acute myeloid leukemia, where these mutations are less common or often less abundant in patients who have MDS. Here's an example of disorders on the myeloid spectrum of increasing severity from left to right. So from the left, we can start with patients that have age-related clone hematopoiesis, or CHIP, where mutations in DNMT3A are by far the most frequent. And as we move further to the right and we find patients who have maybe a defined clinical disorder, like a cytopenia of undetermined significance with clonality, we see that other mutations become more prominent. Mutations in TET2, ASXL1 become a little bit more common than DNMT3A, and we start to see mutations in TP53 and RUNX1. And then when we examine AML or secondary AML, we see different types of mutations rising to the top. Mutations in FLT3 and NPM1 are the most common mutations in de novo AML, for example. Even the mutations in DNMT3A change their flavor. They tend to be more often a point mutation at the R882 hotspot, and less often the truncating mutations that we see in more benign conditions. We also start to see more cases of IDH mutations and NRAS mutations, suggesting that these are more specific for these disease types. And as you'll see, many of these genes are the ones that do predict eventual transformation. So let's talk about those risk factors that help us predict secondary acute myeloid leukemia after MDS. We do have clinical tools like the IPSS and the IPSSR that take into account a lot of factors, including the blast percentage in the bone marrow, cytopenias, and cytogenetics. And these do a reasonable job of predicting the risk associated with leukemic transformation in patients with MDS. You can see the difference between those patients in the high-risk group and the low-risk group is quite substantial for both of these scoring systems. However, while this is good in aggregate, when you're looking at large populations, it may be less precise for individual patients who you might have in the clinic. And there isn't any great insight into the mechanism of transformation. It doesn't also consider the potential impact of disease-modifying therapy, as these patients in the IPSS and the IPSSR were largely untreated. So an interesting study that sheds light on this came from one of my colleagues, Coleman Lindsley, at the Dana-Farber Cancer Institute, where he compared patients known to have secondary AML to patients believed to have de novo AML. And he looked for mutations that were more common in one versus the other. And he found that mutations involved in splicing and chromatin regulation were much more specific for secondary acute myeloid leukemia, whereas mutations in NPM1 and FLT3 or foreign binding factors, for example, were much more common in de novo disease. He then looked at patients who had serial samples collected during the MDS phase and subsequently during the leukemic phase, to see which mutations had arisen in these patients. And the most common mutations that either had occurred only in the AML sample or that were very small in the MDS sample and expanded in the AML sample happened to be in activated signaling genes like NRAS and KRAS, or in myelotranscription factors like RUNX1, for example, or WT1. Here are a couple of examples of how this might come about. The top is a fish plot of a patient with an early DNMT3A mutation who later requires IDH and finally transforms to AML only when they acquire KIT and CBL mutations, both activated signaling mutations. And below is another mechanism in which that doesn't necessarily occur in that order, but we start with a splicing factor followed by a chromatin regulator and then subsequently an IDH mutation leading to AML. So there seems to be a pattern of mutations that are required in a preferential order that lead to transformation of disease. And there's several other studies that bear this out. This is a nice study by Makashima et al. that examined mutations that are preferentially identified in higher risk MDS and then preferentially identified in patients with secondary acute myeloid leukemia. And in this upper right-hand quadrant are shown those mutations that are particularly more prominent in secondary acute myeloid leukemia or higher risk MDS. And you can see that many of the same activated signaling factor mutations are here: FLT3, PTPN11, and NRAS and KRAS, among others. Importantly, they made a distinction between what they called type 1 and type 2 mutations, where type 1 mutations are actually associated with the worst outcomes, or the worst progression-free survival. And they noted that type 1 mutations tended to be those latest hits. So patients were further along in their disease when they had acquired them. That if they had a type 2 mutation, like those shown in the blue text there in TP53, RUNX1, ASXL1, and so on, those tended to precede the type 1 mutations, the FLT3, PTPN11s, and others. And in particular, the size of the clone appeared to matter. If the type 1 gene clone was fairly large, those patients had a worse outcome, suggesting additional potential for transformation to acute myeloid leukemia. And I'll show you again at the end of the talk how these type 1 mutations appear in other contexts. Now, the best way to look at factors that are associated with transformation is to look at those serial samples, where you start with patients who have MDS and then follow them through their transformation to acute myeloid leukemia. And in a study by Kim et al., they did exactly that. And if you look at the mutational profile of MDS versus acute leukemia, you see that it doesn't look dramatically different. There are a few extra mutations acquired along the way in the AML cases. But more importantly, many of those clones that were present in the MDS case had grown in size, as shown by the pink and red squares, when they look at the difference between the MDS and the AML patient cases. So the change in variant allele frequency suggests that we have a leukemic clone present during the MDS phase that later expands and only gives rise to the AML phenotype when it reaches a certain limit. Now, the genes that tended to grow and expand were the ones that I've been mentioning, the activated signaling genes, and to some extent, genes involved in chromatin and splicing. But as you can see, that the epigenetic regulators didn't change very much in that transformation between MDS and AML, whereas the signaling genes and the chromatin genes tended to increase more, just as was found in Dr. Lindsley's study. Other studies that have looked at a large number of MDS patients have suggested a similar order of acquisition of mutations, with the splicing factor mutations being early events, along with DNA methylation regulating enzymes, followed by mutations in transcription factors, TP53, and ultimately mutations in those kinases. So it seems that that class 1, class 2 model that I talked about at the beginning really only describes a portion of this evolution that may actually begin much earlier with mutations in spliceosome and epigenetic regulators. Now let's talk about the size of the mutant clones. If you find that a patient has an adverse clone during their MDS phase, and that clone tends to be very small, does that portend a different outcome than if that clone was already very large and comprising a large portion of hematopoiesis? Well, it turns out that size doesn't really matter in terms of risk, that even small clones portend a very poor risk if they occur in adverse mutations. And this is shown here in these two plots looking at small clones in ASXL1 or small clones in RUNX1. And it shows you that these subclonal mutations are of significant prognostic importance, as they are likely the ones that will grow and expand and turn into the acute myeloid leukemia. We did a similar study looking at the impact of NRAS mutations, specifically in lower risk MDS patients, where NRAS mutations are actually not terribly common. We did find a few patients that had them, and we noted that their outcome was significantly worse. And in particular, we noted that subclonal nature of these NRAS mutations. If we focus on those patients that had NRAS mutations in that lower risk cohort, we also find that there isn't an association between clone size and outcome. Even patients that had very small clones had very short survival times in many cases. And we realized that we were close to our limit of detection for the size of some of these clones. We wondered if even smaller clones below our limit of detection might also confer an adverse prognosis. And we used a technique called cold PCR to find those very small clones that we were unable to detect with standard sequencing techniques. And we found about twice as many. So we found an additional, in this case, 9 patients that had NRAS mutations. And interestingly, their survival was exactly as poor as those patients that had more overt NRAS mutations that we were able to define with more standard sequencing techniques. And collectively, the survival of this group was inferior to the overall survival of the group, and even inferior to those patients with intermediate 1-risk disease by the IPSSR. So again, very small subclones and adverse genes can be that clone that is likely to progress in the future and confer the poor outcome. A similar story for acute myeloid leukemia after myeloproliferative neoplasms, but since these are disorders that are often defined by those class 1 mutations, the mechanism of evolution is a little bit different. So these are, I'm talking about 2 studies, one that looked at over 1,300 patients with myelofibrosis and looked for risk factors associated with progression in this population. Not surprisingly, age was important, as was severe anemia, and of course, the presence of blasts at baseline. However, the mutational profile associated with progression was a little bit different. Patients with ASXL1, SRSF2, and the IDH genes were the ones who were more likely to progress. Here you don't see mutations of NRAS, KRAS, KIT, SIBL, and others, these activated signaling mutations, in part because most of these patients with myelofibrosis already carried mutations in that class and perhaps didn't benefit from acquiring another one. And the model was fairly powerful. The more factors on this table that patients had, the worse their outcome and the greater likelihood of transforming to acute myeloid leukemia. Now, in patients who have essential thrombocythemia and polycythemia vera, the pattern is a little bit different. Here, mutations of TP53, particularly biallelic loss of TP53, this multi-hit model, tended to be one of the worst features, whereas mutations in RUNX1 and ASXL1 remained high-risk features for this population as well. So interesting to see the slightly different evolution in this patient population. Now, we can extend that further and talk not about necessarily the transformation to secondary acute myeloid leukemia, but even the development of de novo AML from prior clonal hematopoietic states. So in 2 fascinating studies that examined patients who did develop AML, but had banked samples during their pre-AML period, often many years before, we've learned that clonal hematopoiesis is remarkably common in this patient population. In patients who were over the age of 65, nearly 80% of them had clonal hematopoiesis years before they developed acute myeloid leukemia. And if we look at the genes that are involved, we see that there is a preferential difference. In large part, mutations of TP53, IDH, and spliceosome genes are highly associated with the development of AML, whereas these mutations tend to be less common in patients with CHIP or clonal hematopoiesis of indeterminate potential. Very similar findings in a study that looked at 95 patients with AML compared to a control group. Again, they found increasing prevalence of clonal hematopoiesis in the AML group prior to the development of their disease, and some of the same genes were implicated, again, particularly TP53, and in this case, U2AF1, as well as the IDH genes. In fact, in both studies, every patient that had an IDH mutation before developing AML went on to do so. There were no mutations in IDH in the control population, suggesting a very high propensity for patients with this mutation during the clonal hematopoietic phase to progress to acute leukemia, and even prompting other people to suggest doing chemo prevention in this patient population with IDH inhibitors, something we may see in the future. So where do we go from here? And what other things can we use to help predict transformation to acute myeloid leukemia in our patient population? I think a study that didn't really get enough attention at the time that it was published by Shiozawa et al. Looked not at mutations, but at gene expression as markers of risk for leukemic transformation in MDS. They started their study by looking at CD34 positive cells, performing transcriptome analysis, and identifying whether there were any subgroups that could be defined based on the transcription profile. And they found 2 large groups that could be distinguished from each other. One had a transcriptional signal of immature progenitor cells, whereas the other had a transcriptional signal of erythroid and megakaryocytic cells, suggesting that they were probably a little bit further along in a differentiation pathway. But strikingly, there were no cases of leukemic progression in that EMK group, whereas those with the immature progenitor phenotype were the ones that experienced leukemic progression. They noticed that it wasn't unique to their patient population. They could find this in a different group in which they validated the signature. And importantly, the genes that are involved are not surprising. They're genes that we knew, when overexpressed, could be associated with poor outcomes, including BALC, FLT3, MN1, and others. They also realized that by taking cells out of a patient, isolating CD34 cells, then doing a transcriptome was going to be laborious. So they devised a way to look at just bone marrow mononuclear cells, perform the transcriptome there, or look at select genes and see if we could identify the same signature in that patient, in that cell population. And indeed they could. So a much more accessible assay that again defined patients based on whether they had this IMP or immature progenitor phenotype or this EMK phenotype, and noticed that they still have strong differences in the risk of leukemic progression. And when they looked for correlates of these signatures, they found that certain gene mutations and chromosomal abnormalities, like monosomy 7, mutations in NRAS, P53, RUNX1, and others, were highly associated with an immature progenitor phenotype, whereas mutations in SF3B1 and TET2, mutations that are not particularly associated with leukemic transformation or even protective, were associated with this EMK profile. They also went back and looked at those genes that I mentioned earlier in the Makishima study, the type 1 genes that are acquired very late associated with secondary acute myeloid leukemia, and found these were also very highly enriched and highly predictive of transformation to acute leukemia. And the nice thing about this is they arrived at these genes in part by looking at the transcriptional signature and not looking at the genetics, suggesting that these two are complementary. So one of the things that I've often wondered is why we make such a big distinction between higher risk and lower risk MDS, in part based on the blast percentage, but other features as well. We treat these patient populations very differently in practice, whereas those patients that have progressed to secondary acute myeloid leukemia, we are now often treating much more like we treat the higher risk MDS patients. And I've always wondered if a more natural division might be to lump the lower risk MDS patients with those patients who have clonal cytopenias of undetermined significance, that is, cytopenias, somatic mutations, but little dysplasia, and put them together in a group where dysplasia is not a defining feature, but is instead a risk feature. And similarly, lump together higher risk MDS with patients who have secondary AML, where blasts are not, again, a diagnostic feature, but are a risk feature, as these patients are treated more similarly. So this is the type of distinction that we might consider in the future, where we lump patients together based on, in part, their genetics, in part, their biology, and in part, the approaches to therapy that we take with them. And if we look at that study by Shiozawa et al., and we look at gene expression, predictors, and blasts, we see that in those patients that have very few blasts, the gene expression signature carries less weight. But even in those patients that have a high percentage of blasts, we can still use that signature to help identify those patients at greatest risk of progression, and in fact modify their risk that way. So to summarize, I'd say that transformation from MDS to AML often involves clonal evolution or expansion of small pre-existing clones during the MDS phase. Mutations associated with progression are often members of growth signaling pathways, but can involve other genes as well, including chromatin regulators. And finally, the gene expression profiles may help us identify those patients at greatest risk of AML transformation. And we need to look for those mutations that may define emerging AML subclones like FLT3, NPM1, NRAS, and so on, as several of these are actually amenable to intervention in ways that we don't currently use in many of our patients with MDS. So with that, I'll end and happy to take questions during the panel discussion. Thank you.
Bueno, muchas gracias, doctor Rafael Bejar, por esta excelente presentación. Y I am glad to introduce Dr. Raphael Itzykson, who is professor of hematology at the University of Paris, affiliated to the Hematology and Immunology Department of the Hospital Saint Louis in Paris. He is an active member of the Groupe Francophone des Myelodysplasias and Acute Leukemic French Association cooperative groups. His research focuses on the treatment in chronic myelomonocytic leukemia and acute myeloid leukemia. And today's his conference is about a chronic myelomonocytic leukemia. Thanks, Dr. Rafael Itzykson.
Muchas gracias para esta introducción. Yo también voy a hacer mi ponencia en inglés hoy. So today we're going to talk about the management of patients with chronic myelomonocytic leukemia. We're trying to see what are the caveats in the diagnostic assessment of these patients, risk assessment, and treatment plan. So these are the 2016 edition of the WHO criteria for the diagnosis of CMML. And I think it is important to remind everyone a number of specificities of these criteria. First of all, for reasons that are mostly, I'd say, historical, one has to rule out classical myeloproliferative neoplasms before diagnosing CMML. This includes conventional myeloproliferative disorders as well as myeloid neoplasms associated with eosinophilia caused by gene fusions. Now, one must acknowledge that some patients may have bona fide polycythemia vera and monocytosis because actually their clonal makeup is compatible with both a monocytosis, that is the definition of CMML, and erythrocytosis. So again, as is alluded earlier by Rafael Bejar, these diagnostic entities are rather arbitrary, and we are more facing a combination of clones in each patient. So the first thing we have to do, and this can sometimes be puzzling in the daily clinics, is to rule out reactive monocytosis. And the team by Dorothée Salimoglu-Buet and Oriane Bagnabalo proposed a few years ago a very simple two-marker strategy to identify patients with CMML because they have an accumulation of so-called classical monocytes that are characterized by CD14 expression and lacking CD16 expression. Now, a very simple situation where you have a reactive monocytosis versus CMML is not extremely useful. What you can have is patients that have inflammatory disease and long-standing monocytosis, where one may wonder whether they have CMML and some sort of autoimmune or autoinflammatory associated disorder. So this may be more puzzling, and this group has proposed a refined strategy by adding an additional marker, which is called SLAN, to really identify patients that have inflammatory CMML, because they have both CMML and some form of autoinflammatory or autoimmune manifestation. So the other thing that is important is to look carefully at the white blood cell count and to make sure that the patient doesn't have something that is closer to atypical CML, because this entity has actually poorer prognosis than CMML. I am personally convinced that there is a continuum between two entities, but apparently they are considered distinct by WHO classification. So when assessing the symptoms of patients, we are obviously always focusing on the well-known tumor symptoms these patients may have, such as spleen enlargements or skin lesions that can come in a variety of flavors, pleural effusions, etc. But again, as many MDS entities, CMML can be associated with a variety of autoimmune and inflammatory disease that may be a clinical issue to the patient. The list that I've shown on this slide is certainly not exhaustive. One can have all sorts of organized pneumonia, etc. And something that our colleagues that are focusing on MPNs are more aware probably than we are the general symptoms that one can see in CMML. Now, we tend to think that fatigue, for instance, is always caused by anemia, but in some patients, you do have sweats, fatigue that are not related to hemoglobin levels, that are more reflective of the inflammatory milieu that is present in the disease. So regarding risk assessment, obviously, as in all myeloid neoplasms, enumeration of bone marrow and peripheral blast count is crucial. It can be a bit difficult in CMML because of a continuum in the monocytic differentiation in these patients, and one must remember that promonocytes should be counted as blasts in CMML. And these bears, when carefully assessed, these bears prognostic relevance as nicely demonstrated by this study. So WHO recommends 3 tires for blasts, CMML 0 with less than 5% blasts, CMML 1 with 5 to 10% bone marrow blasts, and CMML 2. And there is actually prognostic relevance in doing this 3-tire system, as well as obviously distinguishing between patients with myeloproliferative and myelodysplastic CMML. The international cutoff is 13 gigs per liter for the white blood cell count. This is like a historical criterion, but it's probably a reasonable one. And it clearly shows that patients with myeloproliferative disease have a worse prognosis in every context that this has been investigated. CML cytogenetics has really nothing specific. There are now 2 dedicated CMML cytogenetic risk classifications that are not completely concordant with respect to trisomy 8. One has been proposed by our colleagues from Mayo Clinic, and the other one is an Italian-Spanish collaboration. I tend to say that there are more validated prognostic scores in CMML than there are patients. This is not actually true, but there are a bunch of them available around. Most of them now have been externally validated, and some of them have been benchmarked. And today there is no international standard that has emerged. The CPSS is very convenient because it uses daily parameters that are available in the daily clinics that do not account for gene mutations, so they're really easy to work with. They also have this like 4-group system that we've been used for so many years with the IPSS in MDS. The GFM score we proposed a few years ago includes ASXL1 as a gene mutation, and the molecular CPSS is a variant of CPSS that includes ASXL1, but also NRAS, RUNX1, and ZBP1 gene mutations in addition. And this one hasn't been compared to all of the others, but is presumably the more sophisticated one. However, all of the others, again, have been compared one to another in a large international retrospective data set. And as you can see, they are all pretty much superposable in terms of predicted power. So on a very daily basis, I tend to rely on the CPSS just because it's so convenient. The important thing to do is to always consider transplanted eligibility in CMML patients. Obviously, these are often older and frail, sometimes frail patients, but allogeneic stem cell transplantation is a moving field. We are currently finalizing together with Marie Robin an international study comparing the outcome of transplanted and non-transplanted patients with a very large cohort, and actually careful statistical design, because this kind of comparison is always sort of contaminated with very heavy statistical biases in terms of immortal time bias, etc. But doing as carefully as we can show for sure that patients that have low or intermediate 1 CPSS score never benefit from allogeneic stem cell transplantation unless they transform to AML, whereas patients that are diagnosed with high risk CMML, that is intermediate to high risk patients, may in the long run benefit from allogeneic stem cell transplantation, even though during the first 2 years following transplant, the reduction in relapse risks is really neutralized by the heavy treatment-related mortality that remains with this procedure in CMML patients. So, if your patient is not eligible for allogeneic stem cell transplant, you really have to establish treatment goals, because the in many patients the life expectancy will be closer to 2 to 3 years than to 5 or 10 years. So I tend to have this sort of 4 categories in my mind, considering lower risk versus higher risk, and considering what are the symptoms that are predominant. Are these related to cytopenias, to myeloproliferation? Obviously, some patients have both cytopenias and myeloproliferative features, and these are the ones that are the most difficult to manage. I will just emphasize during this presentation on 2 of these aspects. For myelodysplastic patients with lower risk disease, I really tend to manage them pretty much as I would do with MDS patients. I would just like to stress the management of thrombocytopenia in these patients. Thrombocytopenia in CMML can really be obviously multifactorial. It can be to some extent caused by the enlarged spleen seen in some patients. One has to always consider the possibility that there could be some immune peripheral thrombocytopenia, and I tend to always do some sort of short steroid course to make sure to rule out actually this kind of peripheral thrombocytopenia. We recently completed and presented updated results of a prospective multicentric phase 2 trial that actually accrued 30 patients. Now all of them have been studied. These were really very selected patients that had lower risk disease without any bone marrow blast excess, and they had to have a platelet count lower than 50 gigs per liter. The IWG 2006 response rate with respect to the platelet lineage was quite high in this cohort, with 2/3 of patients achieving a response. Actually, however, those responses were short-lived in most patients. We carefully inspected whether the responses were seen only in patients that could have, to some extent, peripheral thrombocytopenia. This was not the case, and notably patients frequently harbored ROX1 mutations that are crucial for megakaryopoiesis, and the presence of ROX1 mutations did not lead to a lower rate of response. So these results are obviously mitigated, but I think there could be a practical use for TPO agonists in these patients, and notably L-Thrombopag, especially in patients that have to have some sort of planned surgery or that are facing some sort of transient hemorrhagic crisis, because you can really manage that with a short course of L-Thrombopag. Now let's turn to hypomethylating agents. I understand that in the US, these agents are now largely used in CMML. In Europe, the label of azacitidine is pretty much restricted to patients that have myelodysplastic disease with more than 10% blasts, because 10 CMML patients were randomized in each arm of the pivotal MDS trial that led to the registration of azacitidine. We performed some sort of a retrospective meta-analysis of 17 studies that evaluated hypomethylating agents as single agents in CMML. Overall, the response rate is roughly 50%, with a complete response rate that can be up to 25% in this, let's say, the most optimistic series. Regression of myeloproliferative features were seen in these cohorts, but they were poorly captured because most of these series used the MDS response criteria. And I think it's important now we've done an international effort to design a CMML-specific response criteria that account for both improvement of cytopenias, regression of bone marrow blast counts, but also improvement in myeloproliferative symptoms. Even when treating patients with hypomethylating agents, the poor prognosis of patients with myeloproliferative CMML remains true. And two studies, one from the MD Anderson group and one from our group, performed a retrospective comparison adjusting patients using propensity score matching models and found no difference between azacitidine and decitabine. We also looked for very simple genetic biomarkers of hypomethylating agents in CMML, and our findings were pretty much overlapping with what several groups, including, I think, Rafael Bejar, have published in MDS, in that presence of TET2 mutations when ASXL1 is wild type is associated with a higher rate of complete response, that in this multi-center retrospective series also translated with a better overall survival. So obviously patients that have this genetic makeup, TET2 mutations without ASXL1 mutations, are patients that have fairly favorable disease course in CMML, but some of them may be eligible for transplant. So I think in this context, this notion can be interesting, and I tend, I've been right to do so far. I hope to be true in the future. But in patients that are eligible for transplant, I tend to allow a delay of 2 to 3 months for transplant to do to treat them with several cycles of hypomethylating agents to lower the bone marrow blast counts. And it actually works, and I tend to believe that this makes for a better allogeneic stem cell transplant. More sophisticated biomarkers of hypomethylating agents have been investigated. This is work that's been published a few years ago by Ken Figueroa in collaboration with Valeria Santini, devising a specific methylome signature predicting response to decitabine in CMML. We're eager to see whether these can be validated in the recent Dakota trial. In patients that have myeloproliferation, there's clearly no specific, let's say, white blood cell count cutoff telling you that you should start some form of treatment. The question is, in fact, should we try to mitigate myeloproliferation except in patients that have obvious symptoms, such as fatigue caused by high white blood cell count or enlarged spleen? One can see in this very nice study that patients with myeloproliferative CMML have shorter survival despite having similar cumulative incidence of transformation to AML, suggesting that myeloproliferation in CMML worsens prognosis by other means than by fostering transformation to AML. And I think it is important that in the future we design studies investigating co-specific mortality. Now, are these patients progressing even though they're not, going above the 20% threshold of transformation to AML, as we've discussed earlier, or are these patients having inflammatory symptoms related to the high white blood cell counts that is adverse in some sense? There is preclinical and translational evidence of such a scenario. CMML patients often have elevated levels of inflammatory cytokines, as shown in this study that was performed by our colleagues from Tampa. And again, this means we have to do these quality of life studies that are easily available in patients with myelofibrosis, but are currently lacking in patients with overlap syndrome, such as CMML or atypical CMML. This is also true at the transcriptomic level. When you look at the transcriptome of monocytes accumulating in CMML patients and you compare them to age-matched controls, you see an enrichment in a number of inflammatory pathways, including interleukin-6 signaling. This could contribute to a worsening of the disease and potentially, as recently seen in the context of clonal hematopoiesis, in a worsening of their cardiovascular risk as well. And in fact, recently, the prognostic impact of these inflammatory monocytes as assessed by flow cytometry, as I mentioned earlier, was demonstrated even though the cohort was relatively small in size. We tend to use hydroxyurea as a means to cytoreduce patients with myeloproliferative CMML, again without specific white blood cell count cutoff to introduce this treatment. This used to be the only randomized trial I knew of in CMML, specific to CMML, that was carried in Lille, France, quite many years ago, that randomized hydroxyurea versus oral etoposide in advanced myeloproliferative CMML. The overall response rate was much higher with hydroxyurea, and the survival was prolonged, probably because of the mucosal intolerance to oral etoposide rather than differences, let's say, in cell-intrinsic cytotoxic activity. So again, when to intervene? Is there an impact of reducing the white blood cell count and the monocyte count by lowering inflammatory levels in these patients? These are, I think, important and open questions in the field. So, is cytoreduction the best frontline option? These was one patient that was studied at the single cell level quite a few years ago, showing that a one-year course of hydroxyurea led to an increase in the proportion of a TET2 and ROS clone within the stem cell compartment, even though the progenitor compartment had unchanged genetic makeup and the patient had seemingly stable disease. So these kind of anecdotal observations suggested to us that obviously the disease was dynamic and that early interventions would be preferable in these patients. And this was the reason why a number of colleagues in Europe designed quite a few years ago the Dakota trial, where patients that had myeloproliferative CMML and advanced disease defined based on a number of criteria that I will briefly introduce, were randomized 1-to-1 to hydroxyurea, conventional continuous administration, versus the standard regimen of single-agent decitabine, with a primary endpoint of event-free survival. These are the key eligibility criteria of this trial. Patients had to have advanced disease defined as a bone marrow blast excess, Cmml Cytogenetic abnormalities, anemia, high white blood cell count actually established on the neutrophil count, thrombocytopenia, splenomegaly, or another extramedullary disease. They had to be previously untreated except for a short course of hydroxyurea and to be ineligible for stem cell transplant. The results have been presented at the last ASH meeting, and with a median follow-up of now 14 months, the median event-free survival was superposable in the decitabine arm compared to the hydroxyurea arm, being 12.6 months in the Dacogen arm compared to 10.3 months in the hydria arm, with a non-significance by the statistical test. This was also true for overall survival that was in median 18.4 months in the decitabine arm compared to 23.1 a month in the hydria arm of the trial. So probably we can discuss further what explains this sort of mitigating results, but suffice to say that cytoreduction remains a reasonable frontline options for patients with myeloproliferative CMML, and obviously there is an urgent need to have disease-modifying agents or combinations in these patients. So fortunately, the therapeutic landscape is somewhat dynamic. A few years ago, we had some preliminary experience with MEK inhibitors in patients with ROS mutations that were relatively disappointing as single agents. We also had reports with farnesyltransferase inhibitors that were thought to impair ROS signaling. And now we have 3 new agents in the CMML field. One is Roxalitne, that is probably important downstream of GNCSF signaling, that is activated in most patients with signaling mutations. That's probably 2/3 of CMML patients. The Grosifusp is also being investigated in CMML because CD123 expression is also high in CMML cells. And finally, we have phase 1 results with lancilumab, which inhibits the GM-CSF receptor. So there are guidelines that are available, at least to our European colleagues, but I must confess that these are mostly based on expert consensus. They were established prior to completion of the Dakota trial, so they'll have to be updated based on these randomized trial. I'd like to touch a word on Roxalitne. There is now a phase 1/2 trial that has been presented and published. This approach mitigates inflammatory cytokine levels. There are few hematological responses that are captured by MDS criteria because patients tend to have improvements in spleen and general symptoms. And there is a suggestion that this could improve survival, at least based on a historical control. So there's something that needs to be investigated, certainly in combination, for instance, with hypomethylating agents in CMML. The Grosifusp is also remarkably active in reducing splenomegaly in these patients. Now, this is something that can be done, including by a cytoreduction in these patients. Obviously, further studies are needed with these agents that seems, however, are relatively well tolerated in patients with CMML. Finally, because I've mentioned that we eagerly need new therapies, there were really a lack of preclinical model for CMML. There's no CMML cell lines. And now only do we have access to PDX models for CMML, thanks from efforts from the Pedron lab and the Abdelwahab lab, together with Eric Solari. This may in the future allow preclinical drug testing in CMML and rational drug combinations translating to the clinics. With that, I would like to thank all my co-workers and collaborators, especially those that have been involved in the large Dakota trial. This was co-chaired by Valeria Santini, Uwe Platzbecker, and Pierre Fenot, as well as collaborators in the MSK, the Moffitt, Mayo Clinic, and our friends in Australia as well. Thank you for your attention. I'll be happy to take questions.
Thank you, Dr. Itzykson, for your excellent talk, and all the other doctors that had these talks also. And we would like to ask now the public to please proceed to the question and answers, which we will be waiting for them to come in. I would like to ask first to Dr. Itzykson about a patient of ours that it's been like complicated. She's a 64-year-old woman with an CMML. She has hemoglobin 10 grams, and the white blood cell is 60,000, with monocytes more than 6,000, and platelets 20,000. So it's been quite difficult for us to decide what to do. And on top of it, well, we had the molecular, and she has TET2 mutation, she has RANKS1 and probably KRAS. Her CPSS is low risk, and so we are been debating what should we do. Cytoreduction with Idrea, but on the other hand, should we use ASA? Should we use L-Trombopac? What would you do in such a patient?
Well, these are typically the patients that are most difficult to manage, obviously. As I mentioned earlier, I think the first thing to do, even though she has a RANKS1 mutation, is to make sure that there is not any peripheral thrombocytopenia that could be managed, by steroids or rituximab, for instance. So that's the first thing I would do. Then, does she have a very large spleen? I mean,
well, she had a very large spleen, but she came to us after she had been splenectomized.
Okay.
Thinking that she had a ITP. Okay.
So I think in those patients, so as I mentioned, I mean, overall lower risk patients do not benefit from stem cell transplant as assessed by the CPSS. Nevertheless, I think with the RANKS1 mutation and as well NRAS mutation, I think she has poor molecular features. So I think ruling out allogeneic stem cell transplant is probably should not be done definitively, so you should consider that. And I think otherwise, unless she complains of any symptoms, I would be happy to leave her with her 60 gigs per liter white blood cell count, just to make sure that we respect her platelet levels and cause her little hemorrhage. I think that's what I would do. But obviously, these are typically the patients that would probably benefit for some sort of hypomethylating agents based combinations. Now, you can use hypomethylating agents, knowing that in the first phase you will be facing a worsening of the thrombocytopenia that may be problematic to manage. these drugs are actually good at rapidly reducing the white blood cell count, so that's not so much of an issue. Patients in the Dakota trial that had high white blood cell count were allowed to actually have combination of decitabine and Hydrea, and almost all patients were off Hydrea after one cycle of decitabine. But I'm afraid that given the RUNX1 mutation, you are not going to have a tremendous response to hypomethylating agents. So I think, yeah, my first goal would be to consider stem cell transplant and then maybe leave her be for a while.
Oh, thank you, Dr. Unfortunately, in our country, we can't take these patients, 64-year-old, to transplantation, even though she has an ECOG-1, because preferably because of the platelets and the hemorrhage. But I think, well, we're going to try first L-Thrombopac. Maybe you or dexamethasone, thinking that there's some inflammatory issue. What?
So I think dexamethasone is good if you still, if you haven't rolled out completely ITP, even though she's been splenectomized, you can certainly do a short steroid course, keeping in mind that probably she's going to have a rise in white blood cell counts, but that's not a matter. That's not a problem. I would really be cautious with L-Thrombopac. So most responses we've seen were short-lived, so it's not a definitive problem. So unless she has active hemorrhage, I don't think there's any rush to use L-Thrombopac. Patients that were treated upfront with MDS high doses of L-Thrombopac had steep increases in white blood cell counts that sometimes were not that obvious to manage. So I'm not sure I would rush on L-Thrombopac, actually, even though this would be intuitively a go-to treatment for this kind of treatments, for this kind of patients.
Oh, thank you very much. There's a question from Dr. Boada, for Dr. Santini. She says, in your work about Ven-Asa in relapsed refractory MDS, do the results that you show are global, or are they analyzed by the two cohorts, 14 days and versus 28 days? Dr. Santini, is she in, or maybe she's...
Okay. Do you see me? Do you hear me?
Yes, yes.
Okay. So the data I showed you about the rescue, the salvage of patients with high-risk MDS, patients with Venetoclax have been produced by Dr. Zaidan at Yale, and he used actually the majority of cases was the 14 days. The fact is that, of course, there was myelosuppression. And as you know, in MDS, the myelosuppressive effect of the Venetoclax are much higher. And the dose was 400. And the majority of patients who really had advantage were the ones who achieved more cycles, so more than 6 cycles. So I think I'm still a little bit worried that Venetoclax can be very myelotoxic and myelosuppressive for patients with MDS. So the data are there, so it works, but it should be used with much more attention than we use it in AML.
Okay, thank you. There's another question from Dr. Schuster about to Dr. Itzykson. Would you consider indicating transplantation based only on mutational status in an asymptomatic patient in patients with CMML?
This is a tough one. I think there is really very little data on that matter, and unfortunately, the data that we've had, I think from the MDS field, there's also a large pan-myeloid neoplasm cohort that was published by our Japanese colleagues. Unfortunately, the bad mutations outside of the context of allogeneic stem cell transplant are also the bad mutations in the context of transplant. So I think this is a really difficult question. Maybe Rafael wants to jump in.
I was going to say the same thing, that this is something we debate. If a patient, for example, has a TP53 mutation, we know their outcomes are poor with that transplant, but they are also exceedingly poor with transplant. So those are the patients that we try to direct towards clinical studies, perhaps transplant plus some sort of experimental conditioning or experimental treatment beforehand, or even consideration of maintenance therapy. So this is an area, I think, of great need, and it's not a straightforward decision. If a patient was truly asymptomatic, I think we would probably defer the timing of transplant, however.
Yeah, that's certainly the same. We are accruing these patients, these big kind of patients, to a prospective non-interventional trial, donor versus no donor comparison to see what's best.
Thank you.
Dr. Itzykson, I have a question. One of the problems that we have follow transplantation in chronic myelomonocytic leukemia is the relapse. Which is your strategy trying to prevent the relapse? Use hypomethylating agent or combination with JAK-STAT inhibitors?
So this is a great question. So my bottom answer is because I work in a large hospital with different programs is to trust my bone marrow transplant colleagues. Now, jokes aside, to be fair, transplant is always complicated in CMML patients, and though theoretically you certainly want to intervene in some sort of a maintenance way, either with certainly with hypomethylating agents, because that's the most studied options. There are many patients that, unfortunately, because of GVHD, etc., will be difficult to treat with hypomethylating agents. Now, obviously, because ROX is increasingly used in the management of GVHD, it will be interesting to see in the future, even though this is going to be difficult to disentangle from a statistical standpoint, whether by any chance using ROX post-transplant has any disease-modifying activity. I think this is probably something that we can start studying right now.
Well, Dr. Itzykson, which would be your election treatment in a patient who has lost, in a CMML patient who has lost his response to hypomethylating agents?
Well, again, there's no satisfactory answer, neither in CMML than in any entity. You certainly want to accrue this patient to a clinical trial. If I can do a side comment with respect to clinical trial in CMML, so until CMML was individualized from MDS by the WHO, we were happy that few CMML patients were accrued to pivotal MDS trials and got access to drugs through that means, even though we had not defined data on what the drug was doing in CMML. I'm thinking obviously of hypomethylating agents here. But I mean, our exclusion from MDS of CMML was a chance, I think, because it fostered a lot of work focusing on CMML, both from a translational and a clinical standpoint. And now we're trying to convince companies that CMML is worth investigating. It's obviously an entity that is more rare than MDS, but to some extent it is also more uniform in terms of prognosis and molecular makeup specifically. So I think it's going to be it's sometimes difficult to have access to these post HMA failure trials that are flourishing in MDS and AML, etc. But this is going to be especially important in patients with CMML.
Thank you. Jorge?
No, excuse Soledad, no puedo leer las preguntas yo. There is another question here.
Yeah. Yes.
It's a 58 female, have multiple myeloma with partial response, developed a CML AML1 proliferative non-response after hydroxyurea. How is it indicator of allotransplanting?
Well, again, I mean, this requires very careful discussion with myeloma colleagues. There is obviously quite a few patients that have both myeloid neoplasms and myeloma. This is also true for CMML. We don't have obviously great results with allogeneic stem cell transplant in patients with myeloma. There are so many drugs for myeloma. So I would be really cautious about allogeneic stem cell transplantation. I'm trying to think. We've had a few patients that were treated with hypomethylating agents because their myeloma was controlled, and this has been successful to a certain extent in these patients.
Okay. Thank you.
Thank you. Dr. Bejar, there's a question for you. Given the bad prognosis of DNMT mutation, the 3R822H, is it correct not to consider them as typical mutations of DNMT3 of CHIP? And what would be the persistence after an EMR in patients treated as acute leukemia?
Yeah, so those R882 mutations are hotspot mutations that occur in DNMT3A. And they often occur only on one allele, suggesting they may have some dominant negative activity. Whereas mutations otherwise in DNMT3A tend to be truncating mutations that cause complete loss of function. And we do think that there is a difference between them. It appears that those R882 mutations are much more common in AML, where they account for nearly half of the mutations in DNMT3A, and they're very rare in CHIP. So if I were to see one of those mutations in a patient who had clonal hematopoiesis or MDS, I would be concerned that it does convey a worse prognosis than another type of DNMT3A mutation. Now that said, I'm not aware of any data that suggests that it leads to worse outcomes in AML, where this mutation is much more common. And in fact, one of the early studies suggested that patients treated with higher doses of daunorubicin or idarubicin may actually have better outcomes in the presence of DNMT3A mutations. I'm not sure if that is necessarily changing anyone's practice per se, but I don't consider it to be an adverse mutation in the context of AML, whereas it might be if we found that same mutation in MDS or in CHIP.
And would you consider as a marker for MRD if the mutation is present and after you had treated the patient for an AML?
That's a great question and a much more complicated one because of what we think of when we look for mutations in MRD. Some of these mutations are very early mutations and they reflect clonal hematopoiesis before leukemic transformation. In patients who are treated and their leukemia resolves, they may have persistent clonal hematopoiesis, and that is not necessarily an adverse finding. On the other hand, if a patient does have residual leukemic mutations, even at the 5% threshold or lower, their risk of progression is quite high. So I would need to distinguish whether or not a mutation present in a patient who has had a complete remission is a clonal hematopoietic mutation, a typical CHIP mutation, for example, or if it is truly part of the leukemic clone. And if it is part of the leukemic clone with evidence of residual disease, then I would argue that patient does have higher risk of relapse and may need some further consolidation therapy, perhaps transplant.
Thank you, Dr. Bejar. Well, we have seen a lot of progress the last years in respect to new molecules that are being tested in these diseases. But still we are, I think, not so near to find some really good drugs for our patients. And on top of that, in our countries, in Latin America, first of all, we have not much access to NGS or molecular testing for these patients in most of our countries. and very little also access to high-cost drugs. So we are really far away from what you are being, you have in your own countries. So what would you suggest for us as the group of the GLAM group to do, the steps to take in order to overcome these issues?
Is a general question to all of us or to someone in specific?
I think it is for you, Valeria.
That's
right.
No, I can take it. I have a good suggestion for you that I think should be applicable. You are a great group. You have a lot of patients. You are spread in all Latin America. I think you should really induce pharmaceutical company to lead some studies in your countries, because in this way you could even design them and do a sort of investigation sponsored trial, but you could also ask and push them to have more experimental trials in your countries. I think that this is the way you can build more collaboration and network and give your patients more opportunity to have new compounds. You know, in Europe, we are not as lucky as in the States. They get the best earlier, and we arrive a little bit later with molecules. But I think that we, in fact, work like that, making up a good network in Europe, and we can propose ourselves as, let's say, a big group of collaboration that can have a lot of patients and get results pretty quick, I would say. I think it's very important for patients to have new opportunities and new molecules.
Yes, we agree, and we are going to work on that. It's been difficult, but we will go on trying. And Dr. Fenot or Bejar or Itzykson, do you have another comment?
No, I think following on Valeria's comment, I think we have also to find ways. I think methodologically this is feasible to have some sort of mirror trials if we are to investigate to launch some large multi-center and multinational trials, especially as we focus on rarer entities because of specific molecular criteria, etc. So I think there's also room for transatlantic collaboration here that can also be potentially interesting to companies.
Yeah, I agree with both your statements. I would add that the value of things like genetic sequencing are improved when you have therapeutic options for your patients. If you know that a patient has a particular mutation, like an IDH mutation, but you don't have access to the drug, it's not going to be as significant for that patient to know their mutational status. So having access to those agents will make genetics be more important in the diagnosis and care of patients with MDS and related myeloid disorders.
Sure.
Totalmente de acuerdo.
Gracias, Pierre. Sí, ha sido difícil, pero estamos en esa línea y esperamos que la industria farmacéutica nos coopere para poder hacer este tipo de estudios y poder, digamos, ir desarrollándonos como Latinoamérica, que tenemos un gran potencial.
Sí, creo que se puede hacer a través de la MDS Foundation y también del EMSCO, nuestro grupo europeo que con Francia, Alemania, Italia, España y Países Bajos.
Siempre estaremos abiertos a toda la cooperación que ustedes nos puedan dar.
Absolutamente.
Bueno, ha sido un placer tenerlos con nosotros. Esperamos que el próximo simposio del año 2023 Los esperamos a todos en Chile, esperamos sin mascarillas, sin restricciones, ojalá sea así. Tenemos un lindo país que mostrarles y tenemos muchas ganas de poder abrazarlos personalmente. So, saying no more, I'm grateful to all of you, and I give a way pass to our chair, Dr. Jasterne, to give the conclusions, final conclusions. Thank you very much.
Thank you. Thank you.
Gracias.
Gracias.
Querida gente, bueno, yo voy a cambiar la traducción. Bueno, vamos a empezar con... Quiero dar... Porque realmente las sesiones han sido maravillosas. La máxima calidad que podíamos esperar de los speakers la hemos tenido. Nos hemos sentido, pero más que cómodos, con todos ustedes, los invitados, los speakers, los chairs, y hemos tenido una interacción enorme con la audiencia, a tal punto que realmente han surgido trabajos de colaboración durante el Meetings with the Expert muy interesantes en morfología, en citometría de flujo y genética. Realmente hemos notado y hemos hecho algunas observaciones que hay grupos trabajando en Latinoamérica y muy bien sobre mutaciones, y realmente esas fortalezas las tenemos que aprovechar y las vamos descubriendo con estos eventos. Por otro lado, nosotros presentamos una encuesta para conocer el estado de situación de Latinoamérica en síndromes mielodisplásicos, y la han contestado 256 personas, y vamos a seguir pidiéndoles a muchos más que la presenten y que la respondan, porque vamos a tener una idea exacta de cuáles son esas fortalezas nuevamente y debilidades. Dentro de los remarks que realmente me gustaría mencionar el sistema inmune. Durante el simposio de Novartis se ha puesto en evidencia las novedades, la fisiopatogenia y los futuros target terapéuticos que vamos a tener en nuestros síndromes mielodisplásicos. También en bajo riesgo sabemos que está muy pronto, muy cerca de tener el luspatercept como una nueva terapéutica, así que lo estamos esperando ansiosamente en esta parte del mundo. Como han visto hoy, el Venetoclax en leucemia amiloide aguda, Unfit, realmente funciona, es eficaz, así que esperemos que pase y que suceda lo mismo con los síndromes mielodisplásicos muy pronto. Muy bien, quiero pasar un aviso antes, que los videos de todas las presentaciones van a estar subidas en esta plataforma durante un mes, así que cualquiera que quiera revisar algún video lo puede ver acá en esta plataforma o en la web del grupo GLAM. La web va a estar disponible, así que cualquiera puede acceder a estas filmaciones. Con respecto a, bueno, llegó el momento que realmente me emociona, porque le pedimos al doctor Pierre Fenot que esté presente para el closing. Realmente, doctor Pierre Fenot nos estuvo acompañando desde los comienzos del grupo GLAM, igual que todos, pero realmente nosotros en Orlando, en un ASH, en el año 2015, le pusimos el nombre GLAM, y el doctor Pierre Fenot estaba presente contando su historia del grupo francophone. Realmente nos acordamos muchísimo de nuestra primera reunión, y bueno, lo queremos dar y homenajear, doctor, con un diploma, sencillo diploma que ustedes pueden ver ahora en pantalla, como miembro honorario. Así que, doctor, sabemos que contamos siempre con usted, no hace falta que le entreguemos nada, pero quiero que sepa recibir este premio, si quiere.
Muchísimas gracias, es un verdadero placer estar con vosotros, aunque desde lejos, pero muchísimas gracias. Y quiero añadir también unas palabras por parte de la MDS Foundation, porque nuestro presidente Steve Nineman me ha dicho que no podía estar con nosotros esta tarde, y agradecer al GLAM para la cooperación, la organización de este simposio, y decir que el propósito de la MDS Foundation, por supuesto, es un trabajo de cooperación con becas para investigación biológica o clínica, también todo el trabajo con los pacientes, con los folletos en varios idiomas, y también para el training de médicos e investigadores jóvenes. Y quizás lo más importante, como lo hemos comentado hace algunos minutos, serían ensayos clínicos comunes. Todavía los tenemos entre Europa, el EMSCO y centros de los Estados Unidos a través de la Foundation, y creo que se puede hacer también con el GLAM, con Latinoamérica, porque finalmente lo más importante para nuestros pacientes es disponer cuanto antes de nuevas drogas y nuevos ensayos clínicos. Y muchísimas gracias como miembro honorario, me ha hecho verdaderamente mucho gusto.
Gracias a todos los presentes, y los esperamos 2023 en Chile.
Gracias.
Muchísimas gracias.
Naturaleza.
Tranquilidad. Fiesta. Encuentros.
Pasado.
Música.